Hi dear doctors, welcome to 𝗲𝗵𝗵𝗵𝗺. I am Dr. 𝗲𝗵𝗵𝗺, your mentor and faculty of pediatrics. Today we are going to discuss very important topic. I should say that either in your viva or in your competitive exams, coarctation of aorta is an important topic. So let's start with the topic, that is coarctation of aorta. And before going into the theoretical parts and everything, let me just show you this. Now what is this? Can you see there is a ductus arteriosus? Yes, there is a ductus arteriosus. And coarctation in the simple word means narrowing. Coarctation in the simple word means narrowing. Okay, let me just write down. In the simple words, coarctation means narrowing. So this narrowing can be a pre-ductal coarctation. This narrowing can be a post-ductal coarctation which is going to occur. Okay, so this thing you have to keep in mind. Okay, so this is important. So now can you see here, this is a coarctation which is happening. Coarctation. Okay, so this is a coarctation which is happening. Okay, so this you have to, I just want you to understand. See here, this is also an example of coarctation. Okay, all right. So this is actually important with where you have to understand about the coarctation of aorta. Okay, so yeah, let me just okay. So of course we'll discuss all these images further when we'll be a little well versed with the theory. Let's quickly start with the theory. So what is coarctation? Coarctation is actually congenital narrowing, mostly of the descending aorta. Okay, usually at the site of the ductus arteriosus, either distal or even proximal to that. Okay, but yeah, mostly what you have to understand that it can be pre-ductal, it can be post-ductal, but one thing is for sure that it is going to be distal to the left subclavian artery. So it is going to be what? It is going to be distal to the, so this is the left subclavian artery. So it is always distal to the left subclavian artery. So this is the coarctation of the aorta. Now why it is important to know that it is distal to the left subclavian artery? Because left subclavian artery is going to supply the upper limb. Okay, it is going to supply the upper limb. So just they want to tell you that the upper limb is getting a proper supply, whereas this is the descending aorta. Descending aorta is something which is going to supply the lower limb. Okay, so lower limb might not get the proper blood supply. That's why even if cyanosis develops, the cyanosis is going to develop more in the upper limb and of course very less in the lower limb, and because it is more in the lower limb and less in the upper limb, that's why this cyanosis is called as a differential cyanosis. This cyanosis is called as what? This is called as a differential cyanosis. So this is important for you to remember. Okay, now this coarctation of aorta, okay, coarctation of aorta is seen in the Turner syndrome. How to remember that it is seen in the Turner syndrome is, just remember this, that if I just turn and twist aorta, this is going to cause coarctation. Can you understand? If I just turn and twist aorta, this is going to be a coarctation, turn and twist, so there will be narrowing. So this is how you can just remember that it is associated with what? It is associated with Turner syndrome. Okay, now one is this. Other can be hypoplastic development of aortic arch. So if your aortic arch is not properly developed, this can be other cause. Okay, now it is also associated with bicuspid aortic valve. Okay, just if you want to remember, please remember. And there are some acquired conditions also for coarctation. There are some rarely acquired, but yeah, there are some acquired conditions like Takayasu arteritis. So as the name suggests, it is the arteritis, inflammation. That inflammation leads to narrowing of the lumen. Okay, and of course the severe atherosclerosis also causes the narrowing. Okay, so these conditions are also responsible for the same. Now pre-ductal and post-ductal. Pre-ductal means it is proximal to ligamentum arteriosum. Okay, and the pre-ductal is actually severe. Okay, the pre-ductal is actually severe. Why? Because now the blood is not going to go to your pulmonary vessels also and not going to go to your systemic vessels also. Okay, Whereas post-ductal means, yes, post-ductal means it is a narrowing which is distal to the ligamentum arteriosum. So it is okay. Why? Because at least the some amount of blood is going to go to the pulmonary arteries at least. Okay, it is going to go to the pulmonary arteries at least. Okay, so please understand this. This is important thing which you have to understand. Okay, so what happens in pre-ductal? The pre-ductal is actually the proximal to ligamentum arteriosum, and because it is proximal, this is severe. Okay, so normally, coming on to the pathophysiology, so please understand that a lot of blood is going to come to the left ventricle. So there is a left ventricular hypertrophy which will be there, and because there is a coarctation is there is narrowing, there will be development of collateral circulation via the intercostal and internal thoracic arteries, and they are going to notch above the rib, and this is going to be very prominent in the X-ray as a rib notching. Okay, so intercostal and internal thoracic vessels are going to develop. Can you see? This is the intercostal arteries, this is the internal thoracic artery which is going to be there, and these are going to just notch the ribs like this. So this is called as what? This is called as rib notching. Okay, clear? Yeah. Now, what do you mean by severe neonatal coarctation? Severe neonatal coarctation is actually when there is heart failure, when there is development of heart failure if the PDA is going to close. So what happens? See, if this is a post-ductal this thing, okay, so the blood is going to go to the to the lungs, okay, and oxygen is proper, okay, oxygen is being supplied to the heart muscles also. But what is the issue? The issue is that if the PDA is closed, that leads to a severe neonatal coarctation. Okay, that can even present as a heart failure. So heart failure is going to be there because no oxygen is getting supplied to the heart muscles. So shock can also develop. So what happens in older children? In older children, what happens? Please understand that the left subclavian artery is still receiving the blood. So a lot of blood is going to the upper limb. In fact, the blood which was supposed to go to the lower limb is also going to go to the upper limb, and that is why there is hypertension in the upper limb which is going to be there. And because of development of collaterals, there will be murmurs which are going to be there. Now, since less amount of oxygen is being supplied, okay, less amount of oxygen being supplied to the muscles, there will be chest pain, there will be claudication that is going to occur. Okay, now please understand there is a classical finding. What is the classical finding? Because a lot of blood is going to your radial arteries but not going to go to the femoral arteries. This is called as radiofemoral delay. There will be weak or delayed femoral pulses which are going to be there, and the blood pressure is also going to be higher in the arms than the legs. So radiofemoral delay is a very, very common finding which is seen in the coarctation of the aorta. So if the pulse, if the coarctation is proximal to the left subclavian, okay, if it is proximal to the left subclavian or distal to the left subclavian, okay. So please understand, sometimes the coarctation can even occur proximal to the left subclavian, okay. So it is going to occur on the proximal side to the left subclavian, just like coarctation is happening here. So what is going to happen? The left side is not going to get the supply, but the right side is going to get the supply. Okay, left side is not going to get the supply. So if you remember from your general anatomy, from your upper limb anatomy, the left subclavian artery continues as left axillary artery, and it is going to supply to most of your left side upper limb. Okay, so if in any case the coarctation, the narrowing is occurring proximal to the left subclavian, there will be delayed left radial pulse, okay, versus the right radial pulse, okay. But in this case there is no radiofemoral delay, because of course when your right side, left side radial artery is going to get the blood, at the same time the femoral artery is going to get the blood. You got it? Yeah. But if it is distal to the left subclavian, the radial pulses are synchronous, but there is a radiofemoral delay which I have already explained to you. Now because of the coarctation of aorta, there is a back pressure which is occurring on the left ventricle, and of course there is decreased oxygenation also to the heart muscles, so there is heart failure which is happening. It can even cause aortic rupture or aortic aneurysm. Why? Because a lot of blood is going to get accumulated, the part which is proximal to the obstruction. Okay, and yes, because of this aneurysm, okay, because of this aneurysm, a lot of blood is going to get accumulated there in the aneurysmal part, and this accumulated blood can even cause thrombus formation, and this thrombus formation can do what? Can do the intracranial aneurysms. This might also cause endocarditis. This is important. Now please understand that because of as I've told you, that left ventricle has to do a lot of pressure because there is obstruction in the aorta. That's why there is a left ventricular hypertrophy which can be associated with the right ventricular hypertrophy also. Guys, if you don't know, let me just tell you that the most common cause of right ventricular hypertrophy is actually the left ventricular hypertrophy. Why? Because if the left ventricle is hypertrophied, the left atria pressure is also going to get increased, the pulmonary veins pressure is going to increase, then of course the pulmonary artery pressure is going to increase, and if the pulmonary artery pressure is increased, the right side has to put in a lot of efforts to push the blood forward, and then the right ventricle is going to have hypertrophy. There is cardiomegaly because of the hypertrophy, and there is a rib notching also, figure of 3 sign. Now why there is figure of 3? So figure of 3 sign, why it is there? Let me just try to show you. If I am having the picture in the X-ray, yeah, can you see this? Okay, let me just try to show you. Can you see this? Yes. Why there is a figure of 3? See, this is a normal lumen. Okay, this is a normal lumen. If there is obstruction, so this is going to be like this, this is going to be the 3. So there is a figure of 3 appearance that is going to be seen in the coarctation of the aorta, right? And of course, in order to see clearly, we have to do echo. Okay, echocardiography is important. It's actually the first choice. But now since the problem is in artery, so we have to do angiography, which is actually the gold standard investigation in adults. Collateral circulations, I have told you, the internal thoracic, then anterior intercostal, posterior intercostal, descending aorta. Okay, so this is the collateral supply which is developing and which is actually a life savior. Okay, so internal thoracic going to anterior intercostal, posterior intercostal, and turning into the descending aorta. But it is responsible for causing rib notching. Okay, it is causing rib notching. Okay, now how will you manage that? See, first thing which we have to understand, that we have to keep the patent ductus arteriosus open, so we will give the prostaglandins. Okay, and dobutamine or digoxin is something which is given for the heart failure. So just one thing which you have to remember in adults, okay, it is actually more for adults, that if the gradient, okay, if the gradient before the coarctation and after the coarctation is more than 20, then you have to do catheterization. You're getting it? So if after and before this coarctation, the gradient of blood supply, the pressure gradient is more than 20 mm of Hg, then you have to do catheterization. And if the gradient is less than 20 with severe stenosis, I'm really sorry, let me just rewind this for you. If the gradient is more than 20, while we insert the catheter to check the pressure, we need some intervention. What intervention? Surgical repair. Similarly, if the gradient is less than 20, but there is a severe stenosis, this much severe that the collaterals have started developing, we have to do a surgical repair. And what is the surgical repair? We'll cut the ends and we'll do the end-to-end anastomosis. Or what else you can do? So first thing, you can just cut, okay, this was the stenosed part, so you just cut this part and then close both the parts. This is one thing. Or you can put so if this is a cynosed part, so you can put a bypass graft over there. Okay, or you can do a patch aortoplasty also, bypass graft or a patch aortoplasty also. Okay, so one thing which you have to understand, that we put the stunt. Okay, why stunt we put? In order to prevent the recoarctation. Okay, just so that it is not coming there and coming close again and narrowing again. So in order to prevent that, we do a balloon angioplasty that is going to dilate the vessel, and after that we put a stunt, especially in the case where the recoarctation chances are very high. Okay, So let me just finish up with this that I've shown you. So yeah, this is just a picture for you guys to see the critical coarctation of aorta. So I think what is important in this, there's nothing very important, so I can just skip that diagram. Yeah, now rib notching, yes, you can understand here, rib notching in the coarctation of aorta. So can you see a notching which is going to be there? Okay, notching means that it is paving way for the arteries to wind over here. So this is a notch, which is occurring. Okay, so notching is going to occur. Now this is a computed CT image, okay, with the reconstructional CT 3-dimensional reconstruction of a coarctation of aorta. So reconstruction means that they are going to take the pictures of multiple parts and then reconstruct a image like this. Okay, so 3D reconstruction is also used. This is the aortogram. Okay, this is the aortogram which is going to show you aortic. This I think we have already. Yeah, again see this picture, this is also coarctation, showing the coarctation of aorta. Again here also there is coarctation, there is narrowing which has been shown. Now it's time to do some of the quick MCQs. Okay, so first MCQ is a 4-year-old boy diagnosed with the coarctation of aorta. Using the echocardiography, the physician localizes the lesion to the aortic arch. The aortic arch arises from which of the fetal blood vessels? So the answer is left fourth aortic arch. Okay, left fourth aortic arch. This is extremely important. So they have asked you that this aortic arch arises from what? So it arises from the the arch of aorta arises from the left fourth aortic arch. So please remember this. This is extremely important. So aorta, okay, aorta, and this is going to be FOUR. Okay, so this is first of all fourth, and you very well know that the arch of aorta is coming out from the left fourth arch. Okay, let me just show you this diagram. Yeah, so can you see it is going to the left side? So left fourth arch is important. And yeah, coming on to the ductus arteriosus. Okay, coming on to what? Coming on to the ductus, this question. So what they are trying to tell, that a 2-day-old girl who was previously diagnosed with the coarctation of aorta suddenly goes into the cardiogenic shock. So closure of which of the following structures is responsible? Of course, the ductus arteriosus. Coming on to the next one, coarctation of aorta. Yes, which chromosomal abnormality? So turn and twist. The answer is Turner syndrome. Then then they ask you coarctation of aorta and which is the most commonly associated. So most commonly associated is actually decreased lower extremity pulses. Okay, so pulses are less in the lower extremities. Now if the patient with the coarctation of aorta is presenting to you with the heart failure, presenting to you with the shock, and has got a pre-ductal coarctation, so what will you do? If it's a pre-ductal, you just want it to be open. Okay, so that even if a small amount is going to the patent ductus arteriosus, because it's a pre-ductal coarctation, even if it is a small amount of the blood which is going to the arch of aorta, from the ductus arteriosus, let it go. So that's why we give the prostaglandins to make it patent. All right, so this marks the end of the topic of patent ductus arteriosus. I am very much thankful to you and will see you in the next lecture. Thank you.